بسم الله الرحمن الرحيم. دكتور حسن, Dr. Safar, we are ready anytime you want to start, please. دكتور سفر, نبدأ على بركة الله.
توكلنا على الله. بسم الله والصلاة والسلام على رسول الله. Today, ladies and gentlemen, first of all, I would like to welcome everybody who joined us in this sessions and in this symposium. I would like, on behalf of our significant distinguished speakers, to thank Saudi German Hospital in Asir, especially Academic Affairs, Dr. Hassan Al-Zahrani and his team, to give us this opportunity to be with us in this following coming 2 days. Tonight and tomorrow we have distinguished speakers with us, just in parallel with the world event regarding diabetes, World Diabetes Day. It is the 14th of November, which is this year under label of education to protect tomorrow. Inshallah, I hope I would like to welcome everybody who will join us and to see the expert regarding diabetes and its complications and how to deal with such complications. Let us to start, and before we start, we'd like to welcome everybody who'd like to share with us any comment, any questions. He can either raise his hand or you can write for us in Q&A icon. Inshallah, tonight we have I will talk about the burden of diabetes in KSA and globally as well. This is after that, Dr. Ali Al-Amri will be the next speakers. He will talk about the update in diabetes management. And we hope recently, as surgeons busy every times, I hope Dr. Abdullah, he can join us today and he introduce his topic regarding diabetes and vascular disease. If he joined with us, or otherwise other speakers, he will continue our sessions tonight. Tomorrow, inshallah, we have in the same times, actually after Al-Isha prayer, will start. Dr. Muhammad Al-Shihri is a nephrologist. We will talk about diabetes and renal disease. Any disease, it has impact in his actual psychological manner. And regarding this, Dr. Abdul Aziz Al-Garni will join us tomorrow. Inshallah, he will talk about diabetic and psychological impact. Dr. Yahya Al-Argubi, he's dermatologist. Tomorrow, inshallah, he will talk or tonight, inshallah, as our time today. He will talk about cutaneous manifestations of diabetes. Again, I would like to welcome everybody who joined us, inshallah, within this night and tomorrow, inshallah, we have very important and very knowledgeable sessions. We'll exchange our expert and our knowledge regarding such disease. I hope my voice and my screen was okay for everybody. If there is any problem, just let me to know by raising hand or just write to me, please.
الصوت واضح دكتور، تفضل.
Okay. I am Dr. Safar Shahrani. For those who joined us, I am Associated Professor, College of Medicines, and I am consultant of family medicine. Tonight, I will talk about the burden of disease of diabetes itself. Actually, this disease, it is a multidisciplinary disease. It should be approached by each of us as health professions. And as we know, the global burden of diabetes, it is increasing and remaining largely uncontrolled deficit. All modalities of the treatment and even all modalities of lifestyle modification, and even beside all education materials and all the effort was taken to reduce its burden. As you see in the left side of your screen in front of you, you see the increasing of estimating patient with diabetes. How millions they every government and every institute responsible regarding the health in each countries, they expend a lot of millions to tackle with this such a disease. As you see in last years, it was during the 2000, it was about 151 millions expand to tackle with this disease. And this is increasingly dramatic as we see expected to be more than 643 during the 2023. And most of those patients with diabetic, especially those with type 2, they have poorly glucose control. It around more than 70%. That means it is more than 2/3 of our patient is not controlled and not achieved hemoglobin A1C less than 7. So in our country, in Saudi Arabia, we have 1 in each 5 adult patients, they have diabetes. It's more than 4 million of our population, they live and they are between us with diabetes. So it is important to start a screening programs in everywhere. And as we notice nowadays, parallel to this diabetic days, start a lot of campaigns just to screening, to educate the public regarding this disease. As you know, it is recommended for any Saudi population more than 30 years of age to be screened for diabetic. Unfortunately, those patients with diabetic, they around 15,000 of those patients, they died from diabetes and diabetes complications. And it is expected by 2044, the diabetic patient will doubling the current situation. It will be around approximately 8 million of our populations here in Saudi Arabia. They lived with diabetic. As you know, even with our magic visions in our country 2023, they would like to tackle this problem and to minimize as possible as we can through all institute or sectors responsible regarding the health to minimize this problem. And as you know, it is the main age of our diabetic in Saudi Arabia. For the male, it is around 57 years, and for the female, the age suffering from this problem around 53 years. As you see, this age, it is earlier, and what our vision expect to be increase the age of our population to beyond the 80s. That means it will take more strategic and more policies and more a lot of work together as health provider and paramedics to support our mission regarding this problem. A complication of diabetes itself, it is raising as the problem it is raised actually. In our health, the diabetic complications in our country, most of our patients, about 10% live with nephropathy problems, and 32 living with retinopathy problem, and majorities of our patients, they suffering from problem related to central nervous systems. A lot of dialysis, a lot of renal problem, a lot of acute problem regarding the renal, and that both us and as health providers and as physicians, they dealing with such patient in the pictures to do a lot of works to reduce such complications. Regarding this, reflect the importance of such meeting today, tonight and tomorrow, just to together our expert in each specialties regarding diabetes and has impact regarding diabetes, to hear from them, to know their visions and their approach from their side, and to work as a team regarding this increasing problem in our community. As we said here in the numbers regarding how our patient is achieved a good control of the hemoglobin A1C, and those who's not met, we see the numbers, it is increasing in each year, and from all of our institute, either the governmental or the private sectors. And we see it is still we are not achieving the recommended control, and this data, it is a Saudi National Diabetes Registry. gathering from most of our institute in our country, and it is so a lot of our patients has not achieved the control of diabetes, and the recommendation is still the average of hemoglobin A1C of our Saudi population is still suboptimal. We are, as I say, even with a good medication, with a good of facilities, with a good of resources in this regarding this problem, still we are not achieved the goal to reduce the complication of disease itself. We know the poor glycemic control actually will increase the cardiovascular complications. Either in, as we see in myocardial infarction, it will be increased to up to 65%, heart failure 64%, stroke about the half of our patient, and other cardiovascular event, it will reach to the 62%. And not only this problem, but even the psychological problem of this disease in our population, and the problem it will be not with the patient itself, even with his family, as his neighbors, as his friends, and his community as well. Even if a lot of recommendation regarding what we would like to achieve from our patients, those with diabetes, still we would like to achieve a lot of control regarding hemoglobin A1C should be less than 7, and the time in the range with the normal should be more than 70%. And also regarding the blood pressures, our goals to be less than 130 over 80 for those with high risk, and to be less than 140 over 90 with the usual populations with diabetic, and to raise the physical activity to be more than 150 minutes per week, and to reduce the targeted regarding the lipid profile in this patient. All this just to manage a diabetes and its complication with recommended glycemic control, with lifestyle modification, with lowering blood pressures and controlling dyslipidemia. Also, to live with highly quality of the life, this patient should be from his psychologically manner to be healthy and to be okay all the time. So this reflects to us the importance actually of comprehensive approach in patient with diabetic. As we know, diabetic patient, it is a disease of each organ in our body. So the multidisciplinary team with priority health professions can provide truly treatment and comprehensive perspective on long-term goals of care. All team members should patient-centered language. So nowadays we are not morely talk as patient, label our patient as diabetic, but should be label him as patient or a person with diabetic. This just to not reflect the negative feedback on our patient. And as we know, as health provider, tackle this problem should be active listening and motivation interview to our patient to help him to identify the barriers and difficulties to change. Even with good guidelines and good approach with our patient, still each patient will have unique preference, unique values, and he has beliefs that may affect the way to for the health provider team to be recommend for him a care plan or a treatment that is suitable for that patient. Work with your patient and with caregivers to promote shared decisions to make and to optimize the health outcome and to increase the quality of his life. In summary, as we know, diabetes prevalence it is increasing worldwide, and around 4 millions in our population they live with diabetic, and expected this number it will be doubled in the next years. In the next few years, by 2024, it will be the 7 or 8 million with our populations in Saudi Arabia live with diabetes. So the forms of health economic burden to diabetes complication and how to deal this reflect the importance of our symposium this night and tomorrow, just to bring you the expert from each specialties to give us his knowledge, his updating regarding diabetic and diabetic management regarding complications. Tonight, as we mentioned before, we have 2 speakers, Dr. Ali Al-Amri and Dr. Abdullah Al-Hayza'i. Inshallah, he will join us. They will talk regarding the updating in management of type 2 diabetes and regarding the diabetic with vascular disease. First of all, let me to welcome our speaker tonight, Dr. Ali Al-Amri. He is a diabetologist and family physicians consultant in Ministry of Health in Asir. He is distinguished speakers and he's expert with diabetics and since graduated from program of family medicine and fellowship from diabetology. I would like to welcome him to talk about the management of diabetes, and after that we hope inshallah Dr. Abdullah he will join us. Dr. Abdullah Al-Hayza'i, he is a famous surgeon. He is the vascular surgeon consultant and he is a head of vascular surgery in Asir Central Hospitals. He's famous surgeons in our regions regarding the vascular and the vascular disease. I would like to welcome him today, and I will leave the sessions now for Dr. Ali to start his sessions and to talk about diabetic management update. Dr. Ali, you are with us?
Yes, with you, Dr. Safar. Assalamu alaikum.
حياك الله Dr. Ali, and the mic with you.
Thank you so much. طيب, بسم الله الرحمن الرحيم. الحمد لله رب العالمين. وصلى الله وسلم على نبينا محمد وعلى آله وصحبه وسلم تسليما كثيرا. First of all, I want to thank Dr. Safar for this warm welcoming, and I hope, inshallah, we will get all benefit for this very nice symposium, inshallah, and it will be, inshallah, smoothly. The huge topic I have to present today, but I'm talking about the important thing regarding the updated diabetes management in 2022. And the most important thing, we have 2 big guidelines we can follow up as American Diabetic Association and also the European Association of Study of Diabetes. So they have now agreed for last conferences before 2 months in the last September to give a very good and agreed consensus recommendation about the updated management and type 2 diabetes. And I present for this all slides here together to be simple and with the all references. So let's start. So the paper will be published, inshallah, and slide will be available to be downloaded later on if you want to give it. So my overview here to talk about is the rationale and importance and context of glucose lowering treatment. And we must talk about the therapeutic option for the type 2 diabetes, either by lifestyle or healthy behavioral. And we are entering now what's calling the weight management here, and what is the most important pharmacotherapy to give in such patients. And we give the personalized approach to the treatment on the base of the characteristic as a comorbidities, which is very important now to talk not only to controlling the A1C, but to prevent the other complication. Finally, I will talk about when we put all together, the strategy of implementation for all new updates is very important for the others. So let's go together now for the first thing. So the rationale and importance for the glucose lowering treatment was very important. So my goals now to controlling in my patient in the clinic is not only controlling blood glucose, but the important thing now can be giving is to prevent complication as a cardiorenal complications and to optimizing the quality of the life regarding the patient, like if the patient have complication, regardless of the age, regardless of the hemoglobin A1C or controlling, or maybe have other association disease or chronic disease with the diabetes. So this circle was very interesting. Before, I think more than 10 years, we always focus on glycemic management only. But nowadays, not only glycemic management, we have what calling the cardiorenal protection glucose lowering agent, which is very important. And the new player now are entering as a weight management, not only controlling diabetes, because most of the causes of type 2 diabetes can be related with insulin sensitivity with the increasing of the weight. So the weight management was very important to be entered to as one medication to controlling hemoglobin A1C and also to decrease the body weight to reach to the target goal. Finally, we have the cardiovascular risk factor management, like other diseases like hypertension, dyslipidemia, smoking cessation, and whatever must we put it together to give a very good plan for such patients. So what's the importance for us? If we want to controlling the glycemic, this is really important or not? For sure. So is there any evidence can be following on? Yes, we have the big trials is calling the DCCT, diabetic complication care trials with hemoglobin A1C, as we're saying, between the 7 and the 9%. If we're controlling as A1C to the 7 and the patient with the hemoglobin C with the 9, we have decreasing what's calling the microvascular complication as calling the neuropathy, retinopathy, and nephropathy for sure from 50 to 76%. And we have the big, I think it's like a godfather trials for diabetes is the UK BDS, which is leading to the 25% reduction of the microvascular complication if you're controlling between 7 to 7.9. So the numbers here are really matter for us. So that's the starting for controlling of the diabetes. But after that, not only controlling is enough, we need to give a prevent for the complication to get a perfect controlling in such patients. So what should we do also? Should we focus other than management of glycemic? Yes, we need to do behavioral approach to such patients. What's the medication important can be giving? And the final thing now entering, and they are agreeing for all of the guidelines to give a chance that metabolic surgery have very good targeting to do the diabetic remission. And the meaning of diabetic remission means diabetic go away, not healing, but it is go away to decreasing for insulin sensitivity. So the weight reduction now was very important, and they are estimated by the numbers. So the mostly being seen the strategy to improve the glycemic management, decrease the weight. Please, for the patient, not only by the diet and exercise, we need to do more weight reduction by the medication, as you all knowing, as to decrease the weight as GLP-1. And we have the new game player now is GIP with GLP-1 combination. So we have the weight loss supposed to be 5 to 15%, which was very good to give a very good control of the patient. And they are estimated that if we have 5 to 10% of controlling of the body weight, it will improving the metabolic outcome. That's meaning for the blood pressure will improving. That means lipid profile will improving, and also for blood glucose will be improving, and that lead to decreasing of complication. But if we want to be more increasing to decreasing the weight from 10 to 15%, that will be lead that time to the remission of the diabetes. And we are agree of the number of the 10%. That's why the most medication can be approved by the FDA can be starting from at least 5% loss for the body weight. So first of all, we can say about the controlling on such patient, the patient is center per se as planning for controlling the blood glucose. And as we know, we take this from the ADA guidelines to see the decision, the cycle care of the person. So the management plan, it's only this one you can see here. This is the management we are giving here, but you focus for the all factors here was very important to give a good controlling. So assess the key person characteristics, which is important for the person as we go in. Consider what is the specific factor for the patient, if the treatment, if he can tolerate it or not tolerate it, is there a contraindication or not contraindication? The shared decision, that's the important thing, to see the patient is central in the plans and agree to the management. And after that, we can implementing of our management plan, and we're doing the monitoring and follow up of the patient. And final thing, we are review and agree for the management plan after if the patient are improving or not. And this is our practice here in Saudi Arabia for the most of the physician, either by diabetologists or family physicians or by endocrinologists or internists as internal medicine. We are following these steps precisely. So we have a big dilemma here. It's calling the clinical inertia. And the meaning of clinical inertia is the failure of the healthcare provider to give adequate treatment for such patients. And we have many causes, but the most related causes for the most of the trials was related to the overestimation the care provided, that the care was very good. And the second thing that the doctors was soft reason. We have soft reason to avoid the intensification of the treatment. Okay, you have the maybe borderline controlling diabetes, continue the same medication. This is what I think soft reason. But if you are aggressive to be controlled, you will get a huge benefit. The final thing here we can see it here, the lack of education for the physicians and the training and the practice organization to achieve the therapeutic goal. But inside the Saudi Arabia, I think we have a very good education here because we have a very good programs and we have very good training inside. And after that, we have very good as a conferences to be provided regarding the diabetes, because one of the common disease in Saudi Arabia. So after we saying that the rationale and what's important for diabetic patient, let's go now for the therapeutic option. So with the therapeutic option, starting with the lifestyle, and then we do weight management, and we're starting for pharmacotherapy for type 2 diabetes. So let's go now for the obesity. So we have here the updated trials. This is published in May 2022, that's saying that around 1 billion of people around the world they have living with obesity. So obesity is per se is a disease. It is not a normal behavior or normal change in the body weight. It's disease per se. And we have big project here is calling for the obesity and the severe obesity prevention. That's showing that in 2030 exactly, maybe 50% will be population in United States will have obesity, and 25% will have morbid obesity. So it was very big, huge challenge inside the United States, and also it will be following inside the Saudi Arabia. So we have now many trials that going as a cross-sectional trials for estimated the prevalence of the obesity inside the Saudi Arabia according to the 2030 and the 2045. So the intensive structural weight management here, we have big trials according direct trial. This is a randomized controlling trial. So showing that the effecting of weight reduction regarding the bariatric surgery and the pharmacotherapy, it can cause any remission or not. So you can see here, when we're following patients after 1 year to 2 years here, it was if you have more than 15 kg, they will have mean participants achieving the percentage to have 2-year follow-up of diabetic remission. So if you have 10 kg reduction at 2 years with the follow-up, they have big chance to have diabetic remission. And also by percentage can be reached from the 10 to the 15% as we can see here. So let's go now for the management of the type 2 diabetes as a medical therapy. So we have big medications now implemented in the United States, and it will be implemented inshallah next year in Saudi Arabia. So we have the semaglutide, as known as Ozempic, we have the 2.4. The semaglutide, Ozempic in Saudi Arabia is we have 0.25, 0.5 and 1 milligram. But regarding for this medication, semaglutide 2.4 is calling as a trade name is Wegovy. It will be inshallah launching in Saudi Arabia next year. And we have the new medication combination is calling GIP with GLP-1. It is the tirzepatide, which is was the most effective therapy regarding the weight management, better than semaglutide. So you can see that semaglutide 2.4 can be reached now to decreasing for the body weight, reaching up to the 10% of the patient, or 10% of the participant can be entered for this trial. But when you're going with the tirzepatide here, surrounding for the patient, participant can reach up to 15%. It can be reached up to 80% here, or more than 80% to decreasing for the weight. So let's go for tirzepatide by kg. You can see when we're reaching and titrated to the upper dosing, we can reach up to 12.4 kg, as around 13.1% weight reduction alone from this medication. And further now, for the non-insulin therapy, tirzepatide was the #1 for decreasing for A1C for almost around 2.1 to 2.6% of A1C reduction by this medication alone. So it was very good, not FDA approved in Saudi, but inshallah next year will be approved. But the problem for us was very huge cost for such medication. So let's go now for the metabolic surgery. Is metabolic surgery until now more effective for controlling for the such a medication? Yes, you can see here from the bariatric surgery, either by gastric sleeve gastrectomy or was Roxane Y gastric bypass. You can see that the glycemic control comparing with medical therapy was better than medical therapy per se to cause a remission. But for the weight loss was hugely improvement, can be reached more than 30% of weight reduction. So until now, the metabolic surgery was one of the magical treatment can be given in such patients with type 2 diabetes. So until now, this is agreed by ADA per se and agreed by European Association of Study of Diabetes to achieve the maintenance of the weight management goal by lifestyle advice and intense evidence-based structural as weight management program for the exercise and also for the diet. And if not improving, we are considering for the weight loss and management by medication. And if not improving, we can go in directly to the metabolic surgery. So this was very good choice for such a physician to give a very good controlling for the patient. Okay, so let's go now for the behavioral therapy. So we have what we're calling the sedentary lifestyle, as we're calling the sitting lifestyle, and we have the sweating, which is improving to give a good controlling of diabetes, and we have the stepping, which was now the most effective now programming to going with the decreasing of the body weight and also decreasing for hemoglobin A1C, and the strengthening exercise that was recommended for the young patient, but for the elderly, I don't think it was very suitable for them. And the final thing that we are missing for our patients, sleep for the patient with diabetes. The sleep are important to controlling for such patient to give an adequate life. Okay, so let's start for the first. We have using the sitting or the breaking up the prolonged sitting. We can using this maybe every 3 minutes. If we have patients sitting more than 30 minutes, we want to increase more to have do resistance exercise, or we can removing out as most of the patient can be work inside the chairs or inside the office. Sometimes the resistance exercise was very good. So the second thing here was calling the moderate to vigorous activity as a sweating. That means to giving the encouraging for the exercise. And this is exercise until now was the main recommended until now. So more than or equal 150 minutes per week. You can separate it in the week by the days if you can doing. This was very good to decreasing of A1C and also to have a good for not increasing for the weight or sometimes slightly to decreasing for the weight. So that was very good. But for the physical function or frailty or what's calling the sarcopenia for the elderly, we must give a very good safety netting for such patients that cannot have trauma because maybe we enter for other complication. So now they are talking about the stepping exercise. So it's increasing by what's calling the steps per day was very good. Very good outcome, both randomized control trial. Very good outcome regarding diabetes also management as to giving as 500 steps per day was very good to decrease the cardiovascular or mortality, and 5 to 6 minutes of the brisk intensity walk may be equal as a 5-year greater life expectancy, and this was very good number for us. So let's go now for the strength exercise. The resistance exercise was very good, but for not the elderly, I think for the other patients less than 60, I think was very good. Maybe can be used to decreasing for the A1C, and also for the building for the body was also very good. So let's go now for the sleep. What's the importance or aim for the sleep? And the last recommendation that agree, the long sleeping more than 8 hours are not good. And the short sleeping less than 6 hours also are not good to controlling diabetes. So between 8 and 6, this is the suitable time to giving to the patient, and the quality for the patient to giving one time was very good. The irregular sleep was not good. It was associated with the poor glycemic level, unfortunately, other than the diet, other than the medication. So we need to give a good quality for the sleep. Final thing, we have what's calling the chronotype. It's calling the evening chronotype. Maybe the patients have been shifting the time from the night to the evening. We are preferred to the sleeping in the night, and we are preferred to working, sleeping in the night, yes, and we're working in the light day, okay? So let's go now for the medication. First, finish for the exercise, finish for the lifestyle intervention, first finish from the weight management, and now talking about the medication. So I'm talking each slide by each medication and what's the importance. So we see here the metformin here, still until now recommended as the first line, but for the guidelines, I think for 2023 from ADA, it will changing now that the metformin will step down from the first line to giving the other opportunity for other medication regarding the cardiovascular effect here and the renal effect. Metformin was not the first line. So, but until now, it was very good because it's cheap, available, very good to decreasing A1C. But is metformin good for a cardiovascular effect? Until now, it was neutral for heart failure and for the MACE effect, which calling the major atherosclerotic cardiovascular event was potential benefit, but for the renal effect, unfortunately, it was not that benefit, but it was contraindicated if the patient have GFR less than 30 because very high risk of lactic acidosis. So sometimes the metformin can be associated with the modest weight loss and the good safety profile with low costs. So let's go for the other categories here. We have is sulfonylurea, which was mostly used after metformin. We have the high glucose lowering efficacy was very good, and no difference in the incidence of the major atherosclerotic cardiovascular event between the sulfonylurea and the DPP4, as the big trials called Carolina trial between the glimepiride and linagliptin. But they are asking, is sulfonylurea good for the heart or not? It will have the neutral effect for the heart, and for the renal effect, they have no neutral for progression of diabetic kidney disease. But the one as not recommended, maybe the glimepiride as we're using here in Saudi Arabia is calling all sulfonylurea glibenclamide. No more. We are prescribing glibenclamide here. They are not recommended in chronic kidney disease, but we have the very good thing is glipizide, but it's not now using in Saudi Arabia. But we have the glimepiride here was very good to be using in Saudi Arabia to have initiate conservatively to avoiding hypoglycemia only, but can causing of deterioration of the GFR, no, it was safe to be used. So this was good for us can be using. So let's go for the TZD here. TZD, the thiazolidinones, like we have the pioglitazone, and we have in the United States is calling rosiglitazone. We have the efficacy here. It was very high glucose lowering efficacy, very excellent actually. And the benefit also for the patient with a non-alcoholic state to hepatitis. So patient with the NAFLD or NASH, the preferred to give a treatment is the pioglitazone because decreasing of the incidence of the NASH. And also now the new evidence now for the pioglitazone, it was giving for the patient with ischemic stroke. Patient with recurrent ischemic stroke, pioglitazone was very good to giving in such patients. But the problem for such medication, we have the side effect as a weight gain and fluid retention can be lead to 27% with the using of this medication. So for the cardiovascular effect in the heart failure, it was contraindicated. And for the effect of the major atherosclerotic cardiovascular, I think maybe sometimes pioglitazone decreasing the incidence of ischemic stroke, that was very good as seen in the trial. But for the renal effect, it was no dose adjustment. So one of the good medication can be using in the patient with the GFR less than 30, pioglitazone, but be aware of the side effect. But there is something here is not fair. Maybe many of physicians, they are saying, no, don't use pioglitazone, don't use TZD. For us, no, it can be used, but they are optimizing now the guidelines that dosing strategy was very important. If you want to give as pioglitazone dose, use the lower dose as 15 milligram and use with combination with other therapy like SGLT2 inhibitor or GLP-1 that promote the weight loss for the patient to not increasing the weight and the sodium excretion because decreasing the site of fluid retention. And I use it in my clinic a lot. When I use SGLT2 inhibitor really with the pioglitazone, I have a very minority number of the patients who have lower limb edema. So good. Let's finish now for the other categories. Is calling dipeptidyl peptidase 4 inhibitors, like we have it here as a sitagliptin, linagliptin, and we have saxagliptin, and also we have the vildagliptin, and we have the new medication now are entering as calling allogliptin. So according to controlling for A1C, it was intermediate glucose lowering efficacy. And the early combination, this is we have big trial between the vildagliptin and metformin. It was very good to give a chance for the patient, maybe estimated up to 4 to 5 years, to not to change the medication and to have sustainability of the good controlling of the A1C less than 7.5. So it was very good. Okay, what according to the cardiac? Is it cardioprotection? It was neutral. For the heart failure, it was neutral, and except for the saxagliptin, which is increasing the risk of heart failure for the severe time trials, as we're seeing here. And we have the renal effect here. That was progression for diabetic kidney disease was neutral, but for the dosing and consideration for DPP4, according to the renal problem, the only DPP4 can be using in the patient with the GFR less than 30 is to either linagliptin, which was no dose adjustment, which was very good medication, and we have the sitagliptin 25 milligram can be using in such patient, but it's not that very good decreasing in A1C. So I recommend and recommend to use linagliptin in such patient with the GFR less than 30. Okay, so let's go now for the newer medication here, as we know here as SGLT2 inhibitor. And you can see for SGLT2 inhibitor now, many recommendations are going on since 2017 until 2022. So it was the clinical efficacy here, intermediate to high glucose lowering efficacy. We have here 4 SGLT2 inhibitor in Saudi Arabia. We have the famous one, empagliflozin, following by the famous one also, the dapagliflozin as calling for seizure. And we have also the ertigliflozin that is entering as a new medication. And we have the final thing is canagliflozin. We are not preferred to prescribing this medication because very high risk of the bilateral lower limb amputation. So let's go for the cardiorenal effect. Is it improving for this situation? Yes, for sure. So the first thing, reduce of the major adverse cardiovascular event, reduction of the overall cardiovascular death, which was very good, reduction of the hospitalization of heart failure, and we can see this very clearly. So let's go for the major atherosclerotic or cardiovascular protection like MI or cardiovascular death. We have 2 medication only improving. We have the canagliflozin and we have the empagliflozin, which was mostly available now in the governmental section and also in the private section. And the heart failure here, the benefit was more with the dapagliflozin, empagliflozin, ertigliflozin, and canagliflozin can be using in such patients with heart failure. And the final thing here is the renal effect. Can be progression for diabetic kidney disease if you're giving with very high dose. Sometimes with this medication, this is would give a benefit for diabetic kidney disease to prevent. So we can give it with the patient, even if not diabetic. The diabetic kidney disease we can using for this medication. But what are the contraindication can be using for such medication? We have 2 medication here as empagliflozin and dapagliflozin. The newer FDA target of GFR is 20 and more. So if they have patient 20 and more, you can using SGLT2 inhibitor. But if you have patient less than 20, please don't use such a medication. Okay, so let's go now for the GLP-1 agonist. So good, GLP-1 here was very, very, very good. And it has high to very high glucose lowering efficacy, really amazing. Okay, and it is doing cardioprotective for sure. But for the renal issues, unfortunately, no evidence until now that GLP-1 was declining the progression of the diabetic kidney disease. But some trials, they are showing that it was improving for albuminuria. So let's go for the cardiovascular event. Can be protect the heart? Sure. We have dulaglutide as a Trulicity, liraglutide was Victoza, which is all GLP-1. And we have the semaglutide subcutaneous and not oral was very good for cardiovascular protection. And we have the neutral as other GLP-1 as exenatide or once weekly lexazenatide is not available inside Saudi Arabia as once weekly, but have been neutral for the heart protection. But for the heart failure prevention, it was neutral for GLP-1. So SGLT2 inhibitor, I think, was improving more than GLP-1. So let's go for the renal effects. The progression of the kidney disease, as we say, if they are decreasing albuminuria in 2 medication, we have our 3 medication, dulaglutide and liraglutide and semaglutide, but that was not that significant. So can we say the GLP-1 can be prevent for diabetic kidney disease? As proving, no. But if patient cannot tolerate it, SGLT2 inhibitor, GLP-1 maybe we can use at least to prevent for such complication. And for the dosing and consideration, until now, no dose adjustment can be seen with the GLP-1, so you can use it safely, but please monitoring the patient carefully when when you're using such as medication. Okay, and we have all of the medication with GLP-1 as subcutaneous, except the new medication now. We see it in our market is calling oral semaglutide is Rybelsus, which was very good, can be using to decreasing for A1C and the weight. But according to the cardiovascular, there are no benefit for the oral semaglutide. Okay, so let's starting for the office. We have the first oral semaglutide, GLP-1 is calling Rybelsus. We have this big trial as Pioneer 1 up to the Pioneer 6 and Pioneer 8 or Pioneer also 10. You can show here that the decreasing of the A1C was very good, can be reached up to 1.4 to 1.2. So it was very good. But regarding to the weight loss, it caused weight loss, but we cannot saying it's approved by FDA as a weight loss management. But we can use it as off-label in some patients with diabetes and obesity. Rybelsus and oral semaglutide was very good. So let's go now for the other. If we escalating the dose of the GLP-1 like dulaglutide or semaglutide, it will have benefit more for glucose weight efficacy. So let's start here. We have here the dulaglutide as a Trulicity, as a giving very high dose, as a 3 milligram and 4.5 milligram. Comparing with 1.5, you can see here that the A1C almost was the similar, not that big difference between change, but it can changing for the body weight with the 4.5 milligram to decreasing the body weight more than 5%. It is causing to decrease more than 5%, but is there any improving medication better? Yes, we have here the efficacy of the semaglutide 2 milligram in diabetic patients. This is calling Sustain 40 trials, which is showing that, and it will be improving for the patient, and it will be available, inshallah, in Saudi Arabia after, I think, 6 months as Ozempic 2 milligram. But for the A1C, not that big difference for decreasing, but according to the body weight, it's increasing more, I think, to reach to up to 8% or 7.5% weight reduction in such a patient. So it's not using only for controlling A1C, it was a very good efficacy for weight management. So that was very good. Okay, let's go now for the new medication now we are talking about is calling tirzepatide. So it's combination between GIP and the GLP-1. What's meaning of GLP? It's calling glucose and as glucose-dependent insulinotropic polypeptide. This was following in the duodenum and the gastrointestinal tract, and we have the GLP-1, which was seeing in the jejunum and in the ileum, which is affecting more to decreasing the secretion of the insulin and the early phase of insulin synergism. It was suppressed by these medications. So we have big trials called here the Surpass trial from 1, 2, 3, and 5 we can using here. The most related and was most amazing can be seen here. The A1C reduction here can be reached up to 2%, and sometimes with a very high dose can be reached up to 2.3. Sometimes can be reached also for the body weight to can be decreasing sometime up to 2.4%. So this was very good when you're using tirzepatide, especially with very high dose as a 15 milligram. Okay, what about the weight? You can see here for the tirzepatide 15 milligram, it can be reached similar to 10 milligram. So for diabetic patients, you can reach up to 10 milligram. Not necessary to increase to 15 until, unless the patient have high weight. I think 15 milligram was suitable for such a patient. And this is the A1C can be showing here between the all doses of the tirzepatide. So the reason for not entering into novel Saudi Arabia, the high cost for such medication. I think I prescribe it for my patient in the United Arab Emirates. It was 1,734 dirham or Emirate dirham. So it was very costed monthly. And inside Saudi Arabia, we hope, inshallah, it will be decreased for the cost. So this is the medication. This is the only one, as we're saying, the very high glycemic efficacy, and you can showing that the cardiovascular effect and the renal effect, because this is a new medication, it is under investigation until now and not approved or published for protection. But the preliminary results was very good, I think, for the patient with the MACE as using for the tirzepatide. So it was very very good and but costly, very high. Inshallah, will we see a huge change in the next year for the diabetic management when we're using this tirzepatide as calling as trade name Mounjaro. Okay, so we return back for these very excellent graph here. This is agreed between all guidelines to achieve the weight maintenance goal, as we're saying here, and the efficacy for the weight loss we have categorizing as very high, we categorizing as a high, and categorizing as intermediate and the neutral. So the very high to decreasing the body weight now, they are officially saying that the semaglutide 2.4 and tirzepatide up to 215 milligram was very high to decreasing the weight. High was dulaglutide and liraglutide. Liraglutide no more very high. It was high, but not reaching up to semaglutide or tirzepatide. That's why now Saxenda I'm not using a lot for more than 1 year. I'm not using Saxenda to decrease the weight. I can using for the maybe other medication was very good. Okay, and the other thing for the efficacy approach and glucose lowering, the very high for A1C reduction, all GLP-1 was very good. Okay, and for the high, as maybe can using as metformin, SGLT2 inhibitor, sulfonylurea, whatever the other medication, and the intermediate until now is the DPP-4 medication. Okay, so let's personalize the approach in such patients. I'm not talking a lot. We have only a few slides we will finish. So we return back to this goal for the care, assessing for the key person, and what's the important for the thing to giving. So until now, we are talking about the new evidence, evidence, and evidence. What's the important here? So we have the primary evidence and we have the secondary evidence. The primary here as a cardiovascular outcome trial. We have many trials as calling Amplitude trial, Vertis trial, and the Freedom cardiovascular trials. And we have the heart failure for trials for the SGLT2 inhibitor like DABA, HF for the dapagliflozin, and we have the Solicift with heart failure. This is calling as a Seliqua with lixisenatide. We have the Emperor trial, which is published for empagliflozin, was very good, and we have the Emperor Preserve trial. The renal outcome, we have the DABA CKD and the SCORE trial only, and we have published now before 3 weeks exactly the EMBA CKD trials, and I am talking about it now. Okay, the secondary evidence, the meta-analysis can be talking on, and this is the meta-analysis I can quote from them, the new treatment. So nowadays, the using of glucose lowering therapy, we see the patient. If the patient have a high risk of atherosclerotic cardiovascular estimation, GLP-1 and SGLT2 was inhibitor. If they are using one or combination, no problem. If the hemoglobin A1C either above the target, you can use the other medication if you want. Okay, patient with heart failure, the SGLT2 inhibitor was very good to give a such patient, okay? And patient with the CKD, until now, the preferable to give SGLT2 inhibitor, but if patient not controlling, we can give GLP-1. And if the patient not tolerating the SGLT2 inhibitor, GLP-1 was very good to decreasing for albuminuria, as we're saying with dulaglutide, semaglutide, and also for the liraglutide. Okay, so as we're saying here for cardiovascular, our atherosclerotic cardiovascular disease, GLP-1 superior, and then SGLT2 inhibitor proving for cardiovascular benefit, and maybe you can use both of them, or if not improving, you can use other medication with combination. So the final consensus recommendation here, the people established with cardiovascular disease and GLP-1, it was very good. SGLT2 inhibitor can be given with the patient with the MACE and heart failure and kidney outcome. So all of these three are going with the SGLT2 inhibitor. So it was very good and commonly using in Saudi Arabia nowadays. Okay, and the people without to establish the cardiovascular disease, or they have multiple cardiovascular risk factors like age more than 55, obesity, hypertension, smoking, whatever, we are preferred to use either GLP-1 or SGLT2 inhibitor as a starting for the patient to decrease the risk of atherosclerotic cardiovascular disease. Okay, other consensus recommendation now saying about the patient with heart failure, CKD or cardiovascular, GLP-1 now and SGLT2 inhibitor was very good, regardless the use of metformin. So you can use it as a superior than metformin as the first line. And the final thing in the patient with heart failure or CKD or cardiovascular disease, either GLP-1 now or SGLT2 inhibitor can be proving the benefit to decrease the baseline of the A1C. So patients not diabetic now, and you want to using for this medication, it was now recommended to use. The patient with heart failure, no diabetes, use SGLT2 inhibitor. The patient with high weight and they have problem with CKD, heart failure, you can, or atherosclerotic cardiovascular disease, you can using the GLP-1 regardless the diabetes and A1C. So you can give it directly. And this was very good because very good outcome of the trials. So as we're saying here, the heart failure, SGLT2 inhibitor was very good to be giving. And what is the important trial regarding the heart failure and SGLT2? So we have in 2019 that published here is the dapagliflozin heart failure, which was very good to decrease the heart failure around the 21%. And we have the Emperor trial, which calling Emperor Reduce and Emperor Preserve trial for empagliflozin was very good to decrease the risk of the heart failure or hospitalization of the heart failure, reach up to the 27 to the 28%. That was very good. This is published in the This is published in the 2020, and this is published here in the 2021. So this is what was all updated trial for regarding this issue. So we have big, which calling the forest plot here between all of this medication. Can we see that all medication can have good outcome regarding the heart failure and hospitalization? So let's go now for the CKD, maybe talking inshallah in detail with Dr. Mohammed Sheri tomorrow. As we're saying here, SGLT2 inhibitor was very good. And if not improving, we can using GLP-1, or if it cannot tolerate it, GLP-1 was a very good choice to giving. What about the trials here? This is the big trials we have it here. We have the Credence trial with canagliflozin. We have the DABA CKD with dapagliflozin, and we have the empagliflozin, which is published before 3 weeks exactly for the EMBA-CKD. Okay, so the population here with the all trials as patients with diabetes, and the DABA was non-diabetic, but for the patient with EMBA, they are using all patients, either diabetic, non-diabetic, and non-albuminuric. And the number of the patients now was very good, but especially for EMBA was higher. And the key and the primary composite outcome, it was decreased the end-stage kidney disease more than 50%, and here as around similar percentage as more than or equal 50% sustained of the GFR, and the result was very good to be published. Sorry, this is old graph for me that can supposed to be published in June 2022, but it's published in October 2022, and it was very good outcome trial. So let's putting all together for these strategies as these things. So the first thing we have, the goal of the care, we have 4 things to are going. So the first thing is the medication are giving. So, and this other here is calling the principle of care we're talking about. So what was very important. And from the out circle here, it was the 4 main categories to controlling for diabetes. So the first one here is the medication of glycemic control. It was choose the approach to provide the efficacy as either medication or combination. Second thing is the weight management, as we're talking about, either to giving lifestyle or to giving the medication for weight loss as tirzepatide or semaglutide was very good, or maybe considering metabolic surgery as gastric sleeve gastrectomy or Roxin or gastric bypass. The third thing here we have calling the cardiovascular, as we're talking about management other than diabetes, so controlling the screening for the cardiovascular disease. Blood pressure lowering was very important. Lipid lowering was also important. Anti-thrombotic agent as aspirin or maybe other medication as a statin was very good. And the smoking cessation also improving for controlling of the patient. Finally, we're going with the red one, as we're saying here, what is the benefit for decreasing the complication as a cardiorenal? As we're saying, is GLT2 inhibitor and GLP-1 was dominant for such controlling blood sugar, blood glucose, and also controlling for the cardiorenal complication. So this is all as put it in one slide. If we want to talk to take a picture, no problem for me. This is the holistic approach for caring for such a patient, and this is the agreed between all of the guidelines to be giving here. So I'm not talking about the using of glucose lowering. This is as knowing here for the ADA 2022, and it will be similar, I think, for ADA 2023. Finally, I'm talking about the insulin therapy. Insulin, I'm talking about other medication. What about the insulin? So the insulin, we are prepared now and to use the GLP-1 before insulin because not increasing for the weight. And the second thing, when initiating insulin, we start with the basal and then intensifying after that if they have premix insulin or have been basal plus or basal plus or calling the basal bolus. And when insulin is initiating, we have continued the organ protective with other medication. Don't initiate insulin without other medication like SGLT2 inhibitor or GLP-1. And can we refer to the diabetic self-medical or management education services if the patient want to using basal bolus therapy? This is the scale of the insulin as we start with the basal, and we can titrating up until we reach to the premix insulin, or can we reach with the basal bolus. But as we're saying, don't forget other combination therapy can be giving with the insulin because it was giving very good controlling. So let's now saying about the technology. We saying here, or we knowing what's calling the CGM, continuous glucose monitoring. So the technology now was very important to have with the smartphone to detect for blood glucose if they have problem or not, and can be using with as insulin pump. So the technology was proving now with the diabetic patient as many application. and we have considered the CGM as we are knowing here as a freestyle Libri or other CGM like we have the Dixicom and other companies in type 2 diabetes on insulin therapy, not in the oral. In the oral, we are not recommended to do CGM. We are recommended with the insulin therapy and adapt the clinical system to optimizing the control technology. So we can now connect between the physician and the patient by the cloud services here to follow up the patient inside his home, and it was very good, really, with the technology. So let's make it work now. This is my home message for all of you. We do everything with the patients, everything done, make it work and worthy for all of the services giving to the patient, starting from the initial treatment until to the controlling of our technology with the patient. This is my presentation here. Pleasure to present this presentation for you. Thank you so much for attending for this presentation. And sorry, I think I'm talking a long time. Thank you so much.
Thank you, Dr. Ali. About your talk and summarizing the guidelines and updating management of diabetic. It was simplified talk regarding a lot of medications, a lot of strategies to achieve a good control with patient with diabetic. Even with that, still the diabetic, it is complicated and it needs a lot of approaches, and we would like to hear from our colleague, Dr. Abdullah Al-Hayza'i, regarding diabetic and vascular disease. I would like to welcome Dr. Abdullah. Dr. Abdullah, the floor is the mic and audio, it is for you.
شكرا جزيلا دكتور سطر، حياك الله يا مرحبا، الله يرضى عليك. وفرصة يعني we'll discuss يعني and we'll share the slide with you regarding the presentation of the peripheral artery disease. واضح الصوت؟
واضح يا دكتور. Actually we'd like to يعني thank you a lot يعني even with your busy in your clinic and your hospital, even give us your time just for your colleague to get to hear from the more senior expert from you. Thank you, Doctor. We'd like to thank more.
شكرا جزيلا دكتور، الله يرضى عليك. أنا أبغى أشارك السلايد. هل واضح عندكم الصورة؟
استنت يا دكتور، يعني في الداون الجرين لايت شير سلايد.
Slide screening. I'm not sure where is it.
Just press.
Yeah, يطلع عندي everything on your screen including notifications, recording, enable notification. Okay, start.
Okay.
I'm not sure what they think. Anything
yes,
clear?
Your screen now. Yeah, just give them time. Yeah, Doctor, you can open your presentation. It will be clear with us.
Okay, good news. Thank you, Hanan. طيب, بسم الله الرحمن الرحيم. I'm not sure is it clear now or does it need to be adjusted? I don't think
I think you are using your phone. It is better to put your phone in the upside يعني.
You're right.
أيوة تكون أكثر وضوحا.
بإذن الله حتى تزبط. خلينا نظبط الأمور لو إنها.
خذ راحتك دكتور، ما في مشكلة. We have time actually.
طيب. بسم الله الرحمن الرحيم. I think إن شاء الله الأمورنا كويسة الحين. طيب. Diabetic foot infection and vascular surgeon. هذا يعني one of the topic اللي غالبا يعني it will reflect for us how it is multidisciplinary team. طبعا what's the problem? إنه actually if we concentrate in the problem الأقدام السكرية في المملكة العربية السعودية, what is the percent, what's the prevalence, and what is the incidence of the diabetes mellitus and diabetic foot. This is the point that we should concentrate on, and to manage our disease and manage our population, we should know how much the prevalence of the disease in our population. علشان كده في new study, it's the national and regional prevalence rate of diabetes in Saudi Arabia. Analyze of national survey data. هذه one of the best study اللي أنا حصلتها صراحة, which is the proportion of the diabetes mellitus was 8.5 among Saudi Arabian population, يعني more than 15 years, اللي أكثر من عمر 15, and it is higher in male and comparing with a female with some percent up to 2% difference. And the prevalence of the diabetes mellitus among age group above 60, it is shooting up to 50%. And this means our so in the study, those above age 60, most of those included in the study, 50% of them is above age 60. طيب, the other point very important, which is the cost of the treatment of such disease. Healthcare expenditure due to diabetes account for 11% of the total healthcare expenditure. يعني لو عندنا ميزانية مثلا مليون أو مليار أو كده for the healthcare system, 11% of it will go immediate for the diabetes and its complication. It is really a risk disease, and it's very important disease that we should concentrate on. So it is not only one disease as asthma or as hypertension or as a simple disease. It's multidisciplinary disease, have a lot of complications and have a lot of multi-organ effects. So pattern of the diabetic foot lesion in Saudi Arabia, experience of King Khalid University Hospital في الرياض. هذه if we observe in this study معمولة في 1991, and it's including almost 1,000 people, peripheral artery disease forming in 50%, and neuropathic was 48%. Prolonged dressing was included in 66%. Amputation was happened for almost third of the patient. It is really disease harming a lot of organs, and one of the organs is the vessel. So economic impact of the diabetic foot ulcer on healthcare in Saudi Arabia, a retrospective study. Also, this is study, and it's reflecting how much it's cost. It's cost actually in 99 patients only, it's cost more, almost 7 million riyal, Saudi riyal, on 100 patient only. And this is very costly disease, and also very costly complication. So simple clinical perspective, هذه one of the most important to understand and to go now in the complication. It is affecting neuropathic in 60%, and in neuroischemic 30%. So the patient, he will come by ischemia and neurological, and pure ischemic in 10% only. So it is neuropathic harming and also ischemic harming, combined neuroischemic, and just ischemic change is in 10%. So if the patient got diabetes mellitus with wound in his leg, so we will observe he will have slower healing, amputation risk, cardiovascular disease, as Dr. Al-Amri mentioned, and some difficulties with peripheral artery disease testing in diabetes. Example, ankle brachial index. It will lead to calcified vessel, so it will not give the proper examination of the vascularity. So simple principle of diabetic foot management. If we observe this foot, as we see, it is for sure the patient he will reach to this wound if he got already loss of his sensation. He will not tolerate any simple one. He will not tolerate the pain simply unless he have loss of sensation. And also he will not reach to this ischemic change without poor vascularity. So to simplify the treatment, we should recognize severe infection and infarction and debride early and debride also adequately for the infection. Simple vascular perspective also, we should look for his vascularity very well. And 85% of the diabetic amputation are avoidable. So this is very important message. So 85% of the diabetic foot or the diabetes mellitus amputation, it can be avoidable if the patient come early. So simple recommendation for the peripheral artery disease in diabetic foot. First of all, the diagnosis, take a history and examination and do proper examination. And the prognosis, 25% better ulcer healing predictor if the oxygen saturation in the foot more than 40. So there is some tissue saturation measurement machine. It is, if it is available, we should take it properly, and if it's not available, we should do proper revascularization for the tissue by angiography or angioplasty. So diabetic foot management, it is multidisciplinary team game. It is not one-man show at all. By all guidelines, they mention it's very obvious. Canadian Diabetic Association and Scotch Intercollegiate Guidelines, and also NIC, Diabetic UK, all of them, they focus on the point that it is multidisciplinary teamwork. It's not one-man show. So we have new friends they should include in the diabetic foot. And it's not only vascular, it's also podiatrician, orthotist, and occupational therapist, social worker, pharmacist, psychologist, dietitianist. Nursing care is very important also. And the medical is the main manager for the diabetes endocrinologist. And we have vascular, orthopedic, plastic, infectious disease, emergency, general practitioner, anesthesia, rehabilitation, psychiatrist, dermatologist, general surgeon, general physician, and radiotherapist. All of those teams, they should include if the patient diabetic have one ulcer. So no single practitioner or healthcare professional can adequately manage the diabetic foot ulcer prevention or management. Do not misunderstood or ignore the patient with ulcer. Otherwise, he will end by Charcot joint. So he will end by severe trauma to his joint from inside with intact skin. He may end by this picture. As we see in the picture, the foot tooth is separated from the metatarsal area and is the intact skin. So admit under vascular is not the proper, I think, decision, but it is multidisciplinary team. Diabetic foot is multidisciplinary team and work in progress. So we should work him first by diabetic team, and then thankfully for our colleague in diabetic foot unit in Nasir Central Hospital, they are managing the diabetic foot and they spreading the approach of the management by the leader, Dr. Manajallah, and we are also included as a part of the team for managing of the vascularity. Team need a game plan. So as we mentioned, infection and admission we should manage, and also the early management by looking for the macro and micro complication, HbA1c, arterial status of his API. All those criteria is very important. In conclusion, diabetic foot ulceration is not simple disease. It's a complex care need by multidisciplinary team, and it's about the patient. And the team need coordination and strategy. The team need to know what success is. Thank you very much.
Thank you, Dr. Abdullah. I'd like to thank your talk regarding one of the most complications and one of the most problem that you're facing in your daily work. Now, I would like to welcome Dr. Ali and Dr. Abdullah. And any questions, any comment from our colleague, you can raise your hand, or you can put your questions in Q&A, and we are happy to answer any questions. I would like to till I revise the Q&A, I would like from Dr. Ali to one of the most talk nowadays, and from either from some health providers or from any physicians, is there any cure regarding diabetes? What is your opinion regarding this comment?
Okay, so for the curing of diabetes per se by medication or not intervention regarding the weight, there is no cure. It's controlling for the diabetes per se. And we have what, as we're saying, is a remission. The remission may go away and maybe return back. And the only way effective to go for diabetic remission is bariatric surgery, especially with patients with the high weight. But let's go with this. Some patients with type 2 diabetes are very thin. So they are not eligible to do weight reduction because they are very thin, are not eligible to do also other intervention for GLP-1 and other medication. There is no cure on such diabetes because it's declining of the function of the pancreas and sometimes may be leading to insufficiency of insulin with other medication like genetic, maybe other cofactors like environmental factors like the diet and other factors, maybe medications, maybe per se can causing for such a problem.
Thank you, Dr. Ali. Anybody from our participant tonight would like to share any questions? You can raise your hand, or you can put your questions in Q&A icon. Dr. Abdullah, you are with us?
Yes.
Yes, Dr. Abdullah, from your expert, what is your advice for all those team you'd like to share in caring of diabetic patient? What's the point you'd like? It is a good point. You can see the patient and you are happy will have a good prognosis. What is your advice regarding this?
Thank you very much, Dr. Sabr. I think it is very obvious. It is from our side regarding this disease. It's not easy disease. Once the patient reaching to the vascular, this means he have a lot of complications and a lot of comorbidities and uncontrolled level until he reached to the this point of the gangrenous and peripheral artery disease. So I think before he reaching to me or you, they need a lot of educational for the population. I think if you ask for my recommendation, I think we need either national strategy or national programs for the diabetes, and to build it in a strong way as the national program of the vaccine that's happened, and all our kids and all our families, they're receiving their vaccine. I think we need national strategy for the diabetes and for the obesity and for the other diseases. I think it started already in the by the vision of Saudi Arabia, and I'm not sure regarding the implementation of this vision strategy for those diseases. It is good to hear from Dr. Al-Amri regarding if there's any national programs for the diabetes and taking it strongly to ask for HbA1c for anyone his age above 40s or something like this.
Actually, we have a very good program now. According to calling the diabetic program care, and we have the diabetic prevention program, Saudi diabetic prevention program, and we have also some Saudi guidelines to following up the patient, starting from the screening, starting for the treatment as initial treatment, and following up for the patient. And also we have a very big program for obesity prevention now, as going with the Saudi Vision 2030. I hope it will be covering really very good outcome in such this huge disease, and also for the huge complication.
And how's
Yeah.
how's it going? Is it strongly implemented, or it is so?
Okay, according for the prevention, still until now ongoing to put final steps for the Saudi program prevention of diabetes. But for the initial guidelines, we have the Saudi guidelines published since 2012, and it was updated the last one in 2020, and it's following the guidelines from the ADA according to the management of the diabetes. But for the prevention, we are still going in the first steps. According to the obesity, still until now, we didn't have a very good or very clear program that's giving a very prevention of the increasing for the weight, and also that implementation such as maybe not only for the medical field, maybe for the other field, like maybe increasing for the exercise, increasing for the diet, but some of the implementation, like we're seeing the calories now, seeing in some restaurants, that was one of the initial steps to decreasing for the weight, to give as education very well for the patient.
Exactly, because this is what we are observing in our community. Implementation by orientation for the population. Anyone he should count his calories, and also the new implementation what we observed, which is implementing of the insurance companies to cover the obesity surgeries. I think this is it is very obvious implementation from the national programs, and we are looking more for the more prevalence or screening for the diabetes. We hope to avoid the complication that reach to us.
As you mentioned, Dr. Abdullah and Dr. Ali, regarding the national guidelines and our vision in our country, it is not the health institute work, it is a multidisciplinary work, and the plan, it is to raise the quality of life and increasing the aging of our population. That means a lot of work should be and effort to be implemented to achieve this goal. Dr. Abdullah, from Q&A, there is one question for you from Dr. I think Muhammad Fuad. He asking regarding is there any role of pneumatic compression therapy device designed to increase artery blood flow and to promote any wound healing? What is your opinion regarding this and use of this compression therapy?
Thank you very much. Thank you, Dr. Muhammad Fawad. He's my senior colleague, and I worked with him while I was intern, and he's now with us also still in Asir Central Hospital, working hardly and strongly. And from this panel, I am thanking him. And yes, it is under study, and it is still, all of it is scattered, papers. It is not well-established papers for this pneumatic compression device to improve the vascularity for the leg. From my practice, I practice it in the severe peripheral artery disease. I practiced in 7 patients. I observed 3 of them, they got benefit. And most of the papers, it is scattered, only 3 papers published in the worldwide. And the highest number is 110 number of the population, with improvement about 30%. So I think with the future plan, it will be implemented. It depends in the publishing of such finding. This is until now it's a new technique, and it is not a lot of papers on it. It need more publishing until it will be implemented as a rule of the management.
Okay, again, thank Dr. Muhammad for his comment and also for his sharing with us this night. Dr. Ali, there is also another question from Dr. Muhammad regarding the use of liraglutide in treating patient with type 2. I think you are covering this during your presentation. Just if you outline the most important and the effect from liraglutide in treating patient with diabetes.
Okay, according to the liraglutide, it was published or was introducing inside the diabetic field, so since 2012 exactly. And for the cardiovascular prevention was in 2014, and for the obesity management as a liraglutide 3 milligram as a Saxenda in 2015. It was very good, really to using. But nowadays it have, I think, multi-challenge for such medication as using as a daily injection, and can be using titrating the dose. When you discontinue, we must repeat the titrating dose after discontinue more than 72 hours. So the nowadays changing down the GLP-1. If you're giving ultra long, it was very good. So nowadays, most of the GLP-1 now introducing was once weekly, was very good, low side effect for sure. GLP-1, unfortunately, sometimes for the cost is still until now very high cost. This is the problem for GLP-1. But for the other GLP-1, it was really low cost comparing with the liraglutide, especially 3 milligram. I think in the future, liraglutide, maybe after 5 years, we will not focus a lot on it. We are focusing for the new generation of GLP-1. And the diabetic field was very hot field. Every year we have new medication. Every year we have a new family that's introducing to treating diabetes and also focusing on the weight management. So liraglutide was good, but I think after a few years, I'm not counting for me. For my personal experience, I'm not using liraglutide for more than 2 years. I'm not using it. I'm using for the new GLP-1, and was very good regarding the A1C reduction and the weight management.
Thank you, Dr. Ali. We will allow Dr. Muhammad al-Shihri to comment with us. You can open the mic, Dr. Muhammad, and share with us your comment.
Assalamu alaikum. Actually, I tried to write my question, but for some reason I'm not allowed to write. So just my question to Dr. Ali.
I hope the others colleagues
yeah, I think so.
face the same problem. Otherwise, our colleague in technical they'll solve it. Even for tomorrow, inshallah.
I can see the questions and I can answer them, but I cannot write my question. So Ali is a friend of mine, and it's been a long time. Actually, ما شفنا بعض فترة طويلة. ان شاء الله
هذه ميزه الويبينارز. it will collect those since long times. حياك الله دكتور علي. يا محمد تفضل.
الله يسلمك. So my question, how available GLP-1? I know في عسير we have empagliflozin, but يعني now we have guidelines. It's for a CKD patient to go after SGLT2 inhibitors to go to GLP-1 directly. So I'm not sure how available in the governmental hospitals. And thank you.
أول شيء ما نرحب بالدكتور محمد الله يجزاه خير, one of the pioneer nephrologists, and we are lucky in the southern region عندنا الدكتور محمد الشهري صراحة جزاه الله الجنة ونتعلم منه دائما. أنا أجي من بعدك دكتور محمد في العلم هذا, but for the SGLT2 inhibitor the availability was very good now, and the cost was very good. So the empagliflozin are available now in any and every primary health care in Saudi Arabia. And the system called Wasfati system, we can prescribe it directly. We have the low dose of empagliflozin 10 and we have empagliflozin 25. According to the other governmental section like National Guard Hospital and the Security Armed Force or Security Armed Hospital, we have the dapagliflozin. So for the governmental section, we are focusing on only 2 SGLT2 inhibitors. We have the dapagliflozin, but the most important, we have the empagliflozin. Armed Force also, they have also the empagliflozin 10 and empagliflozin 25. Availability anywhere to getting from the any primary health care near the home from the patient. They can prescribe it for the 3 months up to the 6 months. According to the diabetic center, also it's available. Sometimes we have shortages, but the primary health care, it was giving for the all GPs, all doctors inside primary health care, they can prescribe SGLT2 inhibitor very easily. But according to the GLP-1, no. Sometimes because very costed, it's only shorting for the diabetic center, but it was, I think, providing for the all governmental section, as we have dulaglutide inside the MOH, and for the Armed Force Hospital, and for the National Guard Hospital, and also I think for the Armed Security Hospital, we have the semaglutide, which was very good. I think in the next year, inshallah, the semaglutide, it will be providing inside the MOH, and not also forgetting about the university hospitals. عشان دكتور سفر هو معنا كذلك في الجامعة، ما ننسى منه. شوف الرجال تغيرت ملامحه شوية. Availability of the GLP-1 and this SGLT2 inhibitor was very good for the all of the hospital.
Thank you, Dr. Ali. أنت.
As Dr. Ali mentioned, I think in our country, alhamdulillah, يعني availability of the most of medications, it is available. Sometimes it is يعني out of stock, but it is not for long times. I think even for the يعني rural BHC, we will see availability of the medications. I don't see any more questions in Q&A. Just I would like to announce for tomorrow talk. We have tomorrow, inshallah, talk regarding renal disease, and Dr. Muhammad, it is our speaker tomorrow. He will give us a lot of talk regarding the dealing with the patient with diabetic and how to protect the kidneys. And also Dr. Abdul Aziz Al-Garni, his psychiatrist, he will give the psychological impact of disease in our patient, which is very important and very it is very effective way to deal with patient in this manner. And also Dr. Yahya Al-Urgubi, he will talk about skin and diabetes. I think because we are in during the work and during the mid of the weeks, a lot of busy with his family and with his children regarding the schools. I am obliged to end the session tonight, and will share with you, inshallah, tomorrow by the 7:30 local time. We'll start our second sessions and second symposium in the second night. I hope we'll see all, and even if you have any questions tomorrow, we'll answer it. Our colleague, it is available to answer it anytime, inshallah. Thank you, our speakers, Dr. Ali and Dr. Abdullah. Thank you for your time, and I would like also to thank all participants sharing with us tonight, and hope you have good informations and good knowledge about diabetic with each organs we are talking about this night. I hope to see you tomorrow, inshallah. I would like to thank Academic Affairs in Saudi German Hospitals, Asir region, regarding his opportunity to share with you tonight. Thank you a lot. Thank our behind the screen, our technicians, they support us tonight. Thank you, Dr. Ali, thank you, Dr. Abdullah, and thank for all.
الله يرعاكم.
Thank you very much.
شكرا.
Thank you. Salam.